Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Hashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. More than 300,000 total hip replacement surgeries are performed each year. Improvements over the past several decades have made the procedure more effective, with less pain and faster recoveries. On today's show, we will learn more about the anterior approach to total hip replacement surgery and its benefits for patients. We are very pleased to be joined by Dr. Stephen Kayiaros, orthopedic surgeon at Robert Wood Johnson University Hospital's New Brunswick and Somerset campuses and clinical assistant professor of surgery at Rutgers Robert Wood Johnson Medical School. Welcome to the show. Thank you for coming in.
Oh, thanks for having me.
Dr. Kayiaros, tell us a little bit about yourself, your background, your history, and where your current practice is.
I was born and raised in New Jersey, and after completing medical school here at Rutgers Robert Wood Johnson, I did my residency in orthopedic surgery at Brown University in Rhode Island, and then I did a fellowship in joint replacement at Hospital for Special Surgery in New York City.
And your practice right now is located?
We're located in Somerset, New Jersey with the University Orthopaedic Associates.
And so right now you're part of Robert Wood Johnson University Hospital, New Brunswick, and will soon be also doing surgery up in Somerset campus.
Correct.
Now tell us about the hip itself. I see you brought a specimen of the hip. The audience has heard all about hip surgery itself. Can you explain to us what the hip is, the joints, the anatomy, just so that they understand what it does and what the reason is for why we do the hip replacement?
Well, the hip is a ball and socket joint to,
In other words, like this.
Yeah, like this, exactly. So here's, a normal hip. And so the ball, this is the ball, and the blue is the cartilage or the natural cushion to the joint. And then this is the socket. And the hip is an important joint because it basically joins our leg to the pelvis and our spine. And so it's involved with, its function helps us walk and do stairs and be able to, do
Even more important, it allows us to stand up.
It allows us to stand up. And so when arthritis affects the hip joint, we start to lose the cartilage. And so once we lose the cartilage, that causes pain, that causes limping, and it interferes with normal everyday activities such as being able to walk long distances, going up and down stairs, putting shoes and socks on, and results in a huge decline in quality of life.
So again, the big thing is we've got this ball and socket.
Right.
When we're born with it, it's nice and it works. It's very easy to move. As we age, the aging process itself, one of the large contributors is osteoarthritis, the regular ordinary arthritis that we hear about on TV, that people take aspirin, Advil, Aleve for. That cartilage in the socket suddenly is no longer as good. We develop pain. We reduce our ability to move.
Correct.
And so the causes of hip pain itself, we know about osteoarthritis. Is there anything else that does it?
There could be other inflammatory conditions around the hip, strains and sprains, certainly. Labral tears, the labrum is a special type of cartilage in the hip, similar to the meniscus of the knee, and that can tear with time and cause pain. Rheumatoid arthritis, not as common now because of the biologic medications that have become available, can also affect the hip. Avascular necrosis or loss of blood supply to the hip can also result in debilitating pain to the hip joint.
So the big one, of course, is the normal aging process, the osteoarthritis.
Correct.
Now, the treatment options for the hip when something like that happens.
Treatment options include conservative modalities such as taking anti-inflammatory medications like you mentioned, physical therapy which can help with range of motion exercises, strengthening the muscles around the hip, using a cane to offload the pressure going across the hip joint can be an excellent conservative treatment. There are injections that are available for the hip joint, like cortisone and hyaluronic acid or gel injections. That's the extent of what can be done from a conservative standpoint.
And again, that's going to be based on the patient's previous history, the age of the patient, the mobility of the patient, and what the future of that patient is. So we're going to treat people differently if they're 40 years old and have bad osteoarthritis versus 95 years old and they have bad osteoarthritis.
Absolutely.
At the same time, that 95-year-old who's very mobile may be just as well for something like that if they're like that. Now, hip replacement itself, when is that actually needed?
Well, hip replacement is the ultimate treatment for end-stage arthritis of the hip when conservative modalities have failed, and when the arthritis has gotten to a point, or the pain has gotten to the point in the patient's life that quality of life has become the pressing issue.
And what happens to the hip when you do a hip replacement?
Well, what actually happens is that we remove the ball part of the hip. And so when we remove we use a saw to saw off the top of the bone. And then what we do is we put in a prosthesis that is going to mimic a ball and socket joint. And so we scrape the inside of the socket or the acetabulum with a cheese grater device, and then we put in a cup which is made of titanium, and that has a plastic liner on the inside. And then on the femur or the thigh bone side, we sculpt the inside of the bone, and then we put an implant which is made of titanium, and that has a little ceramic ball on it, and then the muscles keep it together in place, and it functions like a ball and socket joint, just as like we were born with.
Amazing. Amazing what we can do nowadays.
Yes.
And you do what's called an anterior approach. There are many approaches to doing this. There's the previous ways, the older ways that have been done for a long period of time, and you're doing the more modern version, the anterior approach. Tell us how the differences between the old traditional and the newer modern way.
Well, the anterior approach takes advantage of the fact that we can do the surgery without cutting muscles, and so we're going in between them through a natural interval. The hip is a very deep joint, and so traditional hip replacement surgery involved cutting through the large muscles of the hip. This little model here will kind of illustrates how deep the hip joint is, and so you can see how there are all these muscles that are surrounding the hip. Traditionally, we would have to cut through the gluteus maximus, or the large power muscle, to the back part of the hip in order to access the hip joint. If we kind of pull apart the muscles here, you'll see how the hip joint is really hidden beneath several layers of muscles. With the anterior approach, we're actually able to go in between these muscles without detaching them, and so we're going through a natural interval, and we can access the joint very safely, very effectively, and do the same thing on the inside that what we do with traditional hip replacement surgery.
So instead of going the side view, we're doing it through the front view. By doing that, we're cutting through less muscle.
Correct.
By cutting through less muscle, that means that it's an easier healing process afterwards.
Yes, so not cutting muscle doesn't lead to inflammation. Preserving those muscles results in less pain, and because we're not cutting anything, that leads to a more natural feel to the hip and a quicker recovery for the patient.
So we're sparing the muscles from the cutting, and they also will help in the rehab process also.
Exactly.
And at this point, there aren't a lot of orthopedists out there who have learned the anterior approach.
That's correct. It's actually been around for a long period of time, but training for anterior approach surgery hasn't really been very prevalent. So currently about 20 to 25% of hip surgeons across the nation are skilled at doing this approach.
So the nice thing about having you at Robert Wood Johnson, New Brunswick, and soon at the Somerset campuses is that the patients who are going to need a hip replacement, who are patients who can have the anterior approach, will not need to be traveling into New York City to see an orthopedist in New York City. It can be done right here on campus and have this good healing.
That's exactly right.
So you're introducing us both at New Brunswick and at Somerset to state-of-the-art hip replacement surgery through the anterior approach.
Yeah, anterior approach has really revolutionized the way we do hip replacement surgery. And just now, because it's been more popular within the last 5 to 10 years, we actually have good clinical studies to show that it's not just marketing, it's not just hype, it actually does work.
So what the clinical studies are showing us is that when we look at the two approaches, the old traditional approach versus the current anterior approach, better healing, faster healing, And that's really what the whole idea of this is for.
That's right. And the time that it takes for patients to get rid of their cane after surgery is much quicker. The time that it takes for them to walk normally and navigate stairs normally is quicker. Length of stay is much lower in the hospital. My patients typically go home on either postoperative day 1, sometimes on the day of surgery in younger, more active patients. And so it's really changed the way we do hip replacement surgery.
Very big difference, because I remember having people in for a week in the hospital and then going 21 days to rehab before they even got home. And even when they got home, they really weren't very mobile. So I've got a patient who's 60-something years old, has the osteoarthritis, has been to the rheumatologist, has been to the orthopedist, and I'm sending him over to you. What does the patient do, and what happens when I send them to you if they are a candidate for this type of surgical intervention?
Well, certainly I try to gauge how much the arthritis and the pain is affecting this patient's life, what things they can or can't do. Have they exhausted conservative treatment? And if they're a candidate for surgery, if they're certainly medically fit for surgery, then I would go ahead and recommend surgery for that patient.
And what would that involve for the patient?
The patient involve getting some basic blood work, a cardiogram, a letter of clearance from their medical doctor. They go to the hospital, they get pre-admission testing, they get a joint education class. They meet with a physical therapist ahead of time as well, leading up to surgery.
And then after surgery, the expectations after surgery?
Expectations after surgery is that they'll be walking right away, initially with a walker and then quickly progressing to a cane. The expectation would be maybe 1 night, sometimes 2 nights stay in the hospital, and then going home and having a therapist and a nurse come out to the house and having them recover at home.
Which is unbelievable, to be able to have surgery and be home the next day and actually be able to move at home rather than going to a rehab facility.
Absolutely.
So really big changes. And you said that you have clinical studies now from the number of people you've been doing that show that this is a better approach.
It's a better approach. It's a quicker recovery. There's less pain. There's really not a lot of involved in terms of therapy and recovering. Simple walking is encouraged. And because we're not cutting any muscles, that allows the patient to recover much quickly.
So I assume the complication rate is much less also.
Complication rates is no different than ordinary hip surgery. And so even though this is minimally invasive surgery, it's great, it's still hip replacement surgery, it's still major surgery, and so we have to counsel patients appropriately.
Which again will mean that they still have to follow through, they still need their pre-op evaluation if they're a cardiac patient by their cardiologist, their regular internist or family practice. They'll still need to do everything that they would have had to do prior to having traditional surgery.
Yeah, we still have to make sure that...
it is surgery.
It is surgery.
And with surgery, we always have to be as cautious as possible and prepare them as well as possible. The rehab process, the differences between the old approach and the new approach.
Well, one of the major differences with the old approach is that we had to give patients hip precautions or restrictions. So we had to tell them they couldn't bend their hip past a 90-degree angle, they needed an elevated toilet seat, they couldn't cross their legs, and all these restrictions were to protect the hip from a dislocation or the hip popping out of the hip socket. With the anterior approach, there's no restrictions. I let patients do whatever they want. They can cross their legs, they can sleep on their side, they don't need a pillow between their legs at bed at night, and so that alone, from listening to patients afterwards and having had them recover, is a huge difference, not having that inconvenience of having their do's and don'ts after surgery.
Well, the big thing is no dislocation. Since, again, we're not cutting through that muscle holds it in place.
Exactly.
And being able to actually move the hip and not be restricted, very big difference with the rehab.
Yeah, it's certainly, it facilitates a much quicker recovery.
The big question other people are going to ask now, when they first started hip replacements, there was always the question, after 15 years, does it break down? Do you have to worry about re-replacing and a replacement? What do you do with this one down the road?
In 2018, with the implants that we're using, I tell patients it should last 20 to 25 years, possibly more. So the materials now are manufactured in a way where the wear is essentially negligible. We still have to monitor patients. We still have to get, X-rays at, yearly intervals to make sure that the hip is performing the way we want it to. There's no signs of wear. But hopefully, with the modifications in the manufacturing of the materials, wear and longevity is not going to be much of an issue as it was 20 years ago.
So the person who's 70 years old probably doesn't have to worry about down the road. The person who's 40 or 50, what do you say to them?
I caution them on activity. I tell them that it's possible that they're going to need something down the line, and that they need to come for regular follow-ups, just like you would for any other annual checkup that you would go, whether it's for your heart, whether it's for your teeth. You've got to go and get your hip checked once a year, just like taking your car in for an oil change, so to speak.
And now you said it's made of, what was the material?
The actual, the bearing surface is a ceramic or a porcelain ball, and that's on a high-grade plastic or a polyethylene liner.
And again, we're putting that into the femur, so we're using some type of surgical glue to put it through?
We use a press fit now, so 20 years ago we used to put these in with a grout or a bone glue, but now we have implants that have a porous coating on them, and so the bone will actually grow to the implant over time, and that makes for a lifelong bond and a better longevity because it won't break down like cement breaks down after 15 or 20 years.
Wow.
Yeah, it's pretty cool.
That is pretty cool because I remember the glue that they had to use. Very different, that it actually grows into that. So, tell us from your perspective, why would, if I'm a patient, why do I have the old approach? Why do I have the anterior approach?
For my patients, I always advocate for the anterior approach. I pretty much do it in about 98% of first-time patients who need a hip replacement are getting an anterior approach. It makes more sense to me. We're not cutting muscles from the back. We're not violating tissues that stabilize the hip. It's a quicker recovery for the patient. There's less pain. For me, it's a no-brainer.
Is there any reason not to do the anterior approach? Is there some reasons?
Yes. So sometimes if patients have had previous surgery on their hip, if they have complex anatomy that doesn't allow us to do the surgery safely from the front, then those patients, they'll still need a hip replacement, but we'll have to do it the traditional way.
So, again, you've been doing these for so many years. Patients probably want to know, from your perspective, how has it changed it? How, you've done, when you graduated, you had the old approach. Now you have the new approach. Are people coming in now thanking you so much? How things are so much better.
Oh yeah, I mean I've had patients. It's interesting because I've had patients where they've had a traditional hip replacement done years ago by someone else, but the traditional way. And so it's sort of like they're their own test patient, right. And they've had the anterior approach on the other side, and unanimously they all say it's night and day. It is night and day. The amount of pain that they were in, how quickly they recovered, how seamless it was after surgery. That they tell their friends and their family that if you have to have a hip, get it done anterior. That's the way to do it.
Now there are of course people who are not going to want to have the surgery done. We've got younger people, we've got other people who have other problems. As an orthopedist yourself, what do you do? I send you someone who has a hip injury or even hip pain. What is the approach when I send them to you?
Oh, when I see patients, after a thorough evaluation, I lay out all the options for them. And so patients that either don't want surgery or are not ready for surgery, we want to maximize conservative treatment. After all, this is elective surgery, and so we never want to force anyone to have an operation that they either don't qualify for, they don't want to have. And so there are many conservative treatments that we can offer patients to get rid of their pain and improve their quality of life.
And you would recommend what kind of treatments?
A good course of physical therapy, an anti-inflammatory medication, possibly some injections. That's the mainstay of conservative treatment for the hip.
And as an orthopedist, you would be doing those type of things also. You're not just doing surgery itself.
Correct, yeah, we can do the injections in the office, we prescribe these medications, and we give prescriptions for therapy.
Okay, so without naming anyone, and just share a story about someone who came into your office with the pain or osteoarthritis or something, who had it, and what their quality of life was prior to it and after.
Well, one patient that comes to mind was a patient that I recently treated about 2 months ago. She's actually very young. She was in her early 50s. And she...
By the way, young. You hear that? 50 years
very
old
young,
is very young.
Very young. And she had been complaining of severe hip pain in both hips and leg pain for about a year. And she had seen many doctors, and she was unfortunately kind of being bounced around. And it seemed like no one could kind of figure out what was going on. And she ended up having a minor procedure done on her low back, and she had no improvement at all. And so when I saw her in the office the first time, she was using a walker. You know, imagine a patient in their early 50s using a walker, and she could barely walk. She had no quality of life. And her x-rays just showed terrible arthritis of both of her hips, and I recommended double hip replacement for her simultaneously. And so we did the surgery, and she literally ran out of the hospital. I mean, it was like a 180 overnight. She was so happy. She looked younger. I mean, she was already young to begin with, but just after the surgery, she was out of pain. She was walking very easily, and she was really happy. It was very satisfying to see her finally out of pain and on the road to recovery.
Probably even better for her was to get rid of the walker.
Yes.
You know, she probably was able to return it to someone that probably had a big smile on her face.
Yeah.
So, hip themselves, again, so important because of what we do with it. It's one of the biggest joints in the body, bears the weight. So, a young person, if they're a sports person, is there things that they should be doing to prevent any problems down the road?
Absolutely. You know, the hip joint, as you said, it's one of the biggest joints in the body. It sees up to 3 to 5 times our body weight in terms of forces, and so high impact activities are going to subject the hip to wear and tear. Anything, you know, contact sports or activities that you know, put the hip at a stress, like squatting or deep bends, running. You know, these are all things that, while we do take enjoyment in these activities, can certainly, you know, make the hip wear down the line. I generally recommend low impact cardio work, exercises to strengthen muscles around the hip, as well as, you know, maintaining a healthy body weight and a good diet, because this also helps all of our joints in our body, not just the hip.
So you can be a runner, but you don't want to run on concrete. You'd like to run on something that has less impact. So going to the high school track where it's a spongy surface, better than running on a concrete road.
Yeah, just to absorb some of that energy.
Going on a treadmill, because the treadmill will absorb it, are helpful. Then, of course, even going to a gym or a physical therapist and learning stretching exercises.
Yeah, using an elliptical is good, because that takes away the impact as well. You know, anything in the water is great. You know, aerobics in the water, or, you know, walking in the water. You know, easy forms of exercises.
And for the elderly people, again, to see if there's ways to prevent them from needing a hip replacement, the water exercise is probably one of the better things for them.
Yeah, that's the best bang for their buck.
Unfortunately, not many places that do it, but YMCAs are a good place for it. And there are places that have the silver sneakers where, again, lower impact type of exercises for them. Because what we're trying to do is, we'd love to prevent them from needing the surgery. This is terrific surgery. My God, when I look at this compared to what we learned in medical school, it's night and day. But we'd also love to be able to prevent them from needing it if at all possible. And again, I'd love to send them to you just to get injections so that they can get their physical therapy. But at the same time, the important thing is physical therapy is very important both before and after. A good physical therapist is worth everything.
Oh, absolutely. I mean, being in shape before surgery helps patients, for lack of a better, hitting the ground running after surgery.
Now, as you want to keep them as active as possible. You don't want to put them at bed rest prior to it. Good physical therapist keeps them mobile, keeps them moving, and the same thing afterwards. Allows them to gain full range of motion, allows them to use the hip.
Yeah, the patients that do the best after the surgery are the ones that know the exercises ahead of time, are more mobile before the operation. So it's even a more seamless transition for them after surgery.
Well, one of the good things at your facility, University Orthopaedics, is the fact that you guys have all of that within your own facilities itself. Also, good physical therapy. You have the X-rays, so you do all of the stuff both pre and post also.
Yeah, in our office is really, it's one-stop shopping.
Well, it's not one-stop. What it is it's one excellent way to take care of the body parts, both before and afterwards.
Right.
Well, I'd like to take this opportunity to thank you for coming here, and thank you for explaining the anterior approach to the hip replacement surgery. It's something that many people are hearing about. Many orthopedists in large facilities, tertiary care facilities, are talking about. And it's nice to know that right in our backyard here, we have orthopedists who are very good at doing this and can do it locally, so the patients can do everything locally.
Thank you for having me.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember, the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call us at 1-888-MD-RWJUH. For more information about hip replacement surgery, please visit us at www.rwjbh.org/ortho. Thank you for being here.